Hello, my name is Sam Thenabadu. I'm a consultant in adult and paediatric emergency medicine at the Princess Royal, and this talk will take you through an approach to working in the paediatric ED at the Princess Royal. So paediatric emergency medicine is a wonderful specialty, and obviously I'd say that as a dual trained consultant in emergency medicine in both adults and paediatrics. But what I want to be honest with you is that all of us, when we approach paediatric emergency medicine, vary through these zones that I've put on the screen here. Many of you will feel anxious about starting and seeing children in an emergency setting, but I assure you, you'll be supported all the way through it. And hopefully you'll feel that you're constantly in a learning zone. And actually, I think in a short period of time, you'll feel in a comfort zone. I always, when I see patients, feel that I vary somewhere between the anxiety and the comfort zone, but that's a good thing to be open and willing to feel like that. One thing I always start any pediatric talk with is by reminding you all that kids are not just small adults. You'll run into trouble if you try and use a similar approach to that of adults, because children are physiologically different, psychologically different, and pathophysiologically different as well. So really important to remember there are similarities, I'll give you that, but that we do need to have a pediatric head on when we're seeing these kids. But I do want to assure you it's going to be okay. You definitely know more than you think you do, and all of those skills that you'd have learnt in good history taking, good examination, working out differential diagnoses, those things will come in hold you in good stead in the next period of time that you have with us in paediatric emergency medicine. Some of you will have seen this Dunning-Kruger effect, where at the beginning you know nothing and you feel really, really worried. And sometimes a little bit of knowledge is a dangerous thing. All I ask that is in paediatric emergency medicine and in the adult side, that you always remember where your competencies lie and never feel worried about asking for help. One thing that I always like to say is that some of you may be parents, some of you may have looked after children in your time, but coming to an emergency department at the best of times isn't that fun a thing to do. Trying to bring a child to the emergency department really isn't a fun thing to do. And I think when I became a parent, I didn't realize the paraphernalia that came with trying to take a child anywhere, let alone to an emergency department. So if it ever crosses your mind of, OMG, why are they here, be it 3 a.m. or 3 p.m., remember this parent, this caregiver has gone through a fair amount of thought process before they've come to the department. There's a fair amount of stuff they need to prepare before coming to an emergency department. Believe me, getting all of this stuff ready is not easy when your child is well, let alone when they're poorly. So please have a little bit of compassion for these parents, these caregivers when you see them. One thing I hate is that infamous comment, do you remember that patient you saw yesterday? Now, remember that child you saw yesterday can strike fear in us. For me, I always want to feel confident that we haven't missed anything. And if there are two things that I'd ask that you always think about in every single child you see is, could this be sepsis? Because sepsis can present in lots of different ways in both adults and children, but much more surreptitiously in children. And could this be abuse? There are lots of types of abuse, and we'll talk about those in due course, but those thoughts must cross your mind when you see any child. So to introduce you to a paediatric emergency department, paediatrics probably makes up about 25% of ED caseload across the country, and that varies depending where you work. Here at the Princess Royal, we have a co-located urgent care centre, so a fair amount of children are seen in the urgent care centre that see minor illnesses and minor injuries very, very efficiently. I'd like to remind you that these patients, children, bring along these people with them called parents or caregivers. Now, that can be daunting in itself, but do remember you've probably dealt with adult patients with relatives that can also be equally challenging. Please just be understanding to them. I'd like to highlight again that the approach is the same. We need to take good histories, thorough examinations, perform focused investigations, come up with relevant differential diagnoses, and think about the appropriate treatments for those. But do remember that the nuances to history, the nuances to examining a child are different. Think about the language we use for different ages of child. Think about the order of examination. It's very rare that you'll sit a child at 45 degrees, sit at the end of the couch and examine them. You may examine them more often than not on dad or mum's lap. You may examine them while mum's hugging them and you just lean over and look into that ear. So think about how to approach it to make the best possible experience for you and the child. Please also remember that most children that come to the emergency department are well. That's okay. But do remember that they have such high reserves that they can be well, and suddenly become very, very poorly. So beware the quiet child that's sitting in your waiting room. So here is my first tip, and I think I'm going to go through 20 tips in rapid sequence. MKAW. All 4 of these children went to an emergency department within 1 week space of time. But MKAW is that most kids are well. Our job isn't to berate those parents, those caregivers for bringing the children, is to work out why they came and to ensure that they are well. 2 of those children are mine, so please don't have a go at me for bringing the children. Tip 2, the main challenge is to confirm no life-threatening illness is present. And as I said, children have very, very high physiological reserves. So it's important that we take good histories, examine them thoroughly, and rule out the most serious things that could be happening. I put this picture up because these 2 children look pretty similar, but one of these children goes on to be intubated in 12 hours' time. Take a minute, pause the slides, have a look at the pictures, and see if there are any clues there that you can think which child will go on and become that unwell. When you see me in the department, you can tell me what you think. I really want to highlight that sometimes those children that look well change, and this thankfully is a much rarer phenomena than meningococcal septicemia. But sadly, in my career, twice on a shift, I've seen a patient be sent home and come back in the same shift unwell and peri-arrest. Time can change things so quickly. So do always think, could it be this? So the next tip is to have a structured approach pre-consultation. And many of you, before you see adult patients, will have the same approach of information gathering. We're very lucky these days with electronic records. We can have a look at previous attendances to the emergency department. We can have a look at previous attendances to the hospital. In some situations, we can even network into other outpatient or other partner hospital communications. So what should you do for paediatrics? Well, listen, have a look at the old cards. Have a look at what the paediatric nurses have said. They will be huge allies to you. We're very, very lucky at the Princess Royal to have an excellent set of nurses across both the adult and paediatric department, and nurses that you can trust. Do take close note of what their triage has said. And for me, I often just take the card and say to the nurse, what did you think about this patient? Have you got any specific worries? It's always good to get information there. An important thing to do is to look to see if that child is on the child protection register. Our nurses at triage will ask this question very openly, and it's very rare for parents to lie. It's important that you understand why they're on the child protection register, and that information is useful before the consultation so that you can ensure that you cover those aspects as well within your history. The next tip is about general observation. This is a playroom here, and when you join the Princess Royal, we'll show you our playroom, which is a very lovely place for kids to wait, to be seen. What we have in there are toys, books, a space to play. It's often a place where you think, well, these children don't look that unwell. Have a look around at the children that are sitting on their parents' laps. Those are the children I worry about the most. Look at their alertness, look at their interaction with a carer, think about their surrounds. As I said, it's very difficult for any of us to go into that playroom and not want to play. So the child that doesn't, just have a think why that is. Simple but obvious things. Look at the appearance of the child. What's their skin color look like? What's their skin turgor look like? And are they in pain? Those are really important first observations. Remember, inspection is everything. My fifth tip is cryptic there. It's control the parent, control the consultation. So first and foremost, who are they? Not every man and woman that comes are mum and dad. We have many families that are single parents. We have many families that live with other members of the extended family. So do clarify who's there, and do they have parental responsibility? The next important thing to think about is, does the child want the adult in the consultation? Now, for some consultations, that will be fairly obvious. A 2-year-old is not going to have a consultation with you alone. But you have a teenage girl, well, it's really important to think, what do they present with? Are they going to be fully honest with you, with the parents there? My take on this is it's always important to try and keep all parties on side. But the patient, our patient is this child, and we need to make sure that we do the best by them. We often hear parents say, Can we just have a little word away from the child? Now, the child on the right reminds me of a child that I saw that was diagnosed with acute leukemia. Breaking that news to a parent that's crying in front of their child isn't the kindest thing to do. So there are, of course, occasions where speaking away from the child is okay. But if you're in any doubt, do come and seek senior help. The next tip, I hope, is one that many of you will think back to medical school and remember being taught about ideas, concerns, and expectations. For me, that's both from the child and the parent. They may not be the same things. So, why did the parent? What does the parent think is wrong? What are they worried about? And what is it that they thought we were going to do today? Did they come because they were convinced that they needed an X-ray, a referral to a specialist? Did they think that they needed to be admitted? It doesn't necessarily mean that you're going to collude with them and say that's what we're going to do. But if we know what's in their mind and put those cards on the table, it's much easier to approach the consultation with honesty. My next tip is about communicating with children. Now, these are different ages of children. I'll flick to the next slide. You can see 4 different children there. The first child looks about just under 1 year of age. The second child is holding up, telling you how old they are too. The next child at the table is with their primary school teacher, and that child is 5 or 6. And the final child is a 15-year-old girl. All of these children we should communicate with. I talk to the babies that I see that are 2-3 days old. I certainly talk to the 2-year-olds. Have a think about what language we use and what their communication skills are at their ages. You would find that perhaps the 5-6-year-old is the most communicative, 15-year-old may perhaps less so. So really important for us to have a think about how and what language we're using. Please can I remind you that however young you feel, you're not as young as them. And trying to be particularly cool with them is really not going to work. I do like to utilize your time in paediatric ED to reorientate yourself with some children's classics and have a think about what language they use and where it comes from and what their social reference points are. Peppa Pig is a big one, Dora the Explorer, Frozen, but think about our older kids as well that will be into things like Minecraft, Fortnite. Really important that not trying to be the child here, but understanding what their social cues are. The next tip is to know about developmental milestones. Now, sometime back in medical school, you would have learnt about the milestones of when children roll, when children sit, when children crawl, when children walk. It's really important to have this in your mind because we need to make sure that when patients present and say, oh, my child rolled off the bed, they're 6 weeks old, that we know in our heads that that's not possible. Children don't roll till they're about 12 weeks or 3 months of age. Oh, my child was walking and he fell down the stairs. Oh, he's 8 months old. That's very unlikely. Children generally start walking about 9 months. Now, there are always exceptions to the rule, but what we need to do is to politely and actively challenge what's happening to make sure that that history is consistent with the mechanism of injury in these cases. So 3 months for rolling, 6 months for sitting, 9 months for crawling, approximately 12 months for walking. There is deviation from this, but have that as a rough marker in your head. The next tip is about focusing on the presenting complaint via the child. I always say that if I went into hospital with my partner and you completely ignored me and just asked my partner all the questions, I'd be pretty cross with you. So why do we go into a consultation room and completely ignore a child? The first thing I do when I go into a room where mum and dad and the child is to talk to the child. What's your name? I'll ask them. How old are you? I'm 5. 15? No, 5. Yeah, it sounds a bit silly, but just try and establish a rapport with that child. And actually, when you talk to the child and show them that you aren't dangerous, you aren't going to cause any trouble to them, the parents will see that you're on side as well, and they'll often soften in their approach. Patient-centered care is what we really need to deliver to all our patients, and children are no different. The next tip, 9B, is really do focus on that presenting complaint and history of presenting complaint. Compared to the adult department, where you'll see fairly elderly patients in our emergency department with significant tomes of past medical history, children generally don't have that. This complaint may be the only complaint that they've ever really had in their time. So spend your time on that and go into it in proper detail. work out the symptoms that they're having and explore those. And then make sure that you do ask the child if you can. Now, some children may be bored, as this little one is here, but do ask them, and they're the ones that know what's happened. Tip 10, a pediatric background is needed. Now, anyone under the age of 12 months, 2 years of age, I definitely would encourage you to take this type of history. And it's good practice to get into asking about the antenatal history, the perinatal history. How was the postnatal period, both for the child and the parents? Then to talk about the developmental milestones, as we just touched upon in the previous slides. Always essential to talk about immunization history. And to ensure if immunizations have been missed, to inquire politely why that is. And if there are patients that are anti-immunizations, it's important for us to maintain our professionalism, but to actively encourage them to understand that these are not problematic. It's not that we will necessarily give the immunizations there, but this could be a window of opportunity to get them back to the GP to discuss it further and hopefully to get immunizations back on track. Important to take drug history, allergy history, of course, and then the family and social situation. For me, even though I mentioned at the beginning that the nursing staff will always ask about the home situation and social care, we as the doctor, we need to be approaching that question as well. And for me, anyone under the age of 5, I'll do it as a 2-part question. I'll say, under the age of 5, do you see the health visitor still? Do you have any help from social services? Over the age of 5, do you have any contact with the school nurse? Do you have any help from social services? Remember, social services these days, thankfully, are not all about taking children away from their families. That's often the worst thing for the child. It's about supporting them through difficult times. Patients can be on the child protection register for a multitude of reasons. It may be an ex-partner that was violent to a mother. So it's important that we aren't judgmental, but we do know the wider story. You may have seen some complex family trees written by pediatricians. We don't necessarily need that in the emergency department, but what I would encourage you to do is to ask who's at home. And if a partner, if a parent isn't at home anymore, so if the birth mother or father has left, is to ask how often do they see dad? Who does dad live with now? Unfortunately, if we talk about abuse, if we talk about neglect, it often comes from within the household, within the immediate contacts. So, tip 12, appropriate examinations. Now, examining a child is not the same as examining an adult. We want you to perform focused examinations, but they need to be thorough, because in pediatrics, the history and examination are everything. So prepare well for it. Have everything ready. Think about the setting I touched upon earlier. Is the examination better on dad's knee, or is it better on the bed? You know, we don't want to cut corners, but we want to make sure the child is comfortable and confident in us. That might be with dad right next to the child if you need to examine the child's belly. It might be with father pulling down the underwear when you briefly need to look at the genitalia. Think about what assistance you need, and that can be with parents. It might be with play specialists. We're lucky enough to have play specialists up on the wards that can come down and join us. We don't always have a bloke dressed as Peppa Pig, but we can try and be creative in how to put children at ease. We need to think about adequate exposure, and it's not appropriate just to examine the child over clothes. We must expose them, and that full examination needs to be under the age of 1. We do not want to miss injuries and non-accidental injuries in that age group in particular. Listen, I'm not asking you to strip a 15-year-old boy with an ankle injury down to their underwear, but do think about special cases where children, say with disabilities, children who are in wheelchairs. We've had tragic stories where children like that weren't examined properly and were the victims of abuse. So do use the carers, use the nursing staff to see how best to examine that child. Examine all the systems always, and remember the ear, nose and throat is so important in children, and put numbers to everything you can. The order of examination may not be from the nails up the arm to the JVP to the chest wall, but make sure you do everything in whatever order seems to fit best. But most of all, leave the most distressing part to last. To stick a tongue depressor in the child's mouth and then to be able to expect to go on and examine the chest is highly unlikely. Think about which order to do it in. With examination, you need to examine a lot of children to understand what children should be like, and especially babies. In the PRUH, under one minor illnesses will be seen by the paediatricians, but I would encourage you to try and see as many children as you can. I and the paediatricians don't really mind who clerks a patient, but we do mind about who makes decisions on patients. So in this situation, we need to get hands-on, and if there are babies to examine, feel free to examine them and present them to the emergency department registrar or consultant or the paediatric registrar or consultant, and learn to understand what handles well mean. It's something pretty special to hold a baby and to be able to comfort a baby, but also to be able to understand if a baby doesn't feel right, if the tone isn't right, if they feel floppy, if they feel rigid, if they feel irritable. Tip 13 is the exam never forgets, and I mentioned the ear, nose and throat often being where the money is at in paediatrics. Do always look at the ear, nose and throat. And if you haven't examined children's ears and nose and throat before, we'll show you the special ways to sit them on mum and dad's lap and how to use their assistance to hold the child to examine them better. Think about the fontanelle in babies, if it's sunken like in this picture, or if it's very tense. Think about the hips in the under ones, if they could be dislocated or dislocatable. And always think about the testes in abdominal pain. Young boys very rarely want to talk about their genitalia and often won't even tell their parents about it. So torsion can be something that just isn't thought about till it's too late. Always examine the genitalia in any abdominal pain. Tip 13 is about never memorizing anything. When I started as a pediatric ED consultant, I thought my role was to know absolutely everything and to be able to recite off the doses of everything. Absolutely not now. Always look everything up. Otherwise, sod's law, you'll make a mistake. And don't get the numbers wrong. The ranges for children vary completely by age. And what we'll do is when you join is to give you a sticker to stick on the back of your badge. And every single child that you see, I'd ask that you look at that sticker and you check those observations. We're very lucky that we use something called the BPUs, Paediatric Early Warning Scores, and the nursing staff will have collated a score. So clearly, just like the News or the News 2 score in adults, we'll see if a child has an elevated score. But it's very good practice and essential practice for you as the doctor to check the observations each time. Tip 14 is about distraction. I talked about examining children and having assistance from family. Well, often the best assistance is the parent's phone and either putting on something from YouTube, putting on that Peppa Pig video, or even looking at pictures of themselves. Children are very good at wanting to look at picture after picture of themselves playing videos of themselves that will distract them while you can examine them, or distract them while you need to perform a procedure. Don't forget the bubbles. Bubbles are a wonderful distraction. They certainly distract me, and they'll definitely distract your children. So do think about those techniques we can use. Tip 15 is Osler's rule, and I hope you've heard it before, that history and examination gives 90% of the diagnosis. Training as a pediatric emergency medicine doctor certainly made my adult emergency medicine better, because I realized that by taking good histories and examination, I got the answer most of the time through that. I'm going to tell you, and not encourage you, but tell you that we do not do baseline routine investigation in children. Unfortunately, we do seem to do that sometimes in the adult world. But here we need to just see how will that investigation change my management. So no routine bloods, I insist. A blood test that we do need to do and ensure we've checked in any child that doesn't seem quite right, that seems unwell, is a blood sugar. DEFG, I'm sure you've heard, is don't ever forget glucose. The children's sugars can vary very quickly, and it's important that we've checked that. Urine dips, bloods, capillary gases, these are things that please ask for advice before you start taking bloods. But if we do need to take bloods, apply some anesthetic cream. It's very rare that we need to rush in and do bloods immediately, so do seek advice from your seniors. A gas is a very useful test, and in our babies, in our children, we can do capillary gases, squeeze the heel samples to get a blood and understand where that child sits in the wellness scale. Chest x-rays, abdominal x-rays, rarely needed for children that are going to be discharged. If you can hear crepitations, if the history fits with chest infection, if it's a productive cough, do you know what? Probably it's okay to give some antibiotics. We don't need an x-ray. They're systemically unwell and they look like they're coming into hospital, well, that's completely different. Abdominal x-rays, even less useful. Constipation is not an indication for an abdominal x-ray. Tip 16 is about the sick children, and we do see sick children in the department as well. And you will have the privilege, and it is a privilege, to be part of those teams that can support those sick children. If we need to be aggressive with our resuscitation, we will be. And we use good boluses. We secure early good access, and that access is intraosseous access. Nobody will expect you to do any of this on your own, but being part of the team and experiencing that is good practice for whatever you want to do in your careers. There are lots of resources, both in the adult and paediatric world, and I would encourage you to have a look at some resources. These are resources I use, and I would, of course, recommend them, but they just allow me to have them as an aid memoir. In the department, we will have intranet guidelines as well, so do ask, but have a look at these resources to see if they can help. Tip 17 is escalate early, and we escalate early within the department. You will find that there's a huge amount of support in our department from consultant and registrar presence, and of course our nursing team. So do ask them if you are worried. But our escalation as a district general hospital, clearly to our ward paediatricians, is to St Thomas's Evelina Children's Hospital intensive care. Unlike adults, if there are children that need to go to intensive care, the team come and retrieve them. So we use the STRS, the South Thames Retrieval Service. Now, it's not common, but you might be the person that phones them up and makes the referral, because you might be the person that has seen the child from the off and knows every single detail. Don't be worried about that. They're incredibly supportive teams, and we have protocols in how to refer to them. And we'll talk through those if ever that's needed. My final tips coming up now, and both important for the adult and pediatric world, is about documentation. Document your salient examination findings, especially ENT. Document what your impression and differentials were, and with that, talk about what you were looking for, talk about what you ruled out. For me in life, I always think about what the most serious thing this could be, the most likely thing this could be, and one other. If you think about 3 differentials, you'll rarely go wrong. Always document your plan. Document the advice that you got from your seniors, and document the advice that was given to parents, and if it was agreed, understood. And always document what the safety net was. Those safety nets may be, go and see your doctor in 3 days' time. It might be, if this isn't better in 4 days, 5 days' time, come back to the emergency department. Have a think about it and make sure the parents understand that safety net advice. Remember, if it wasn't written down, it just didn't happen. And we sometimes have to look at notes a few weeks later, a few months later, sometimes even a few years later. And it's really important to know that the notes are thorough. And with that, I ask you to document who's with the child. So I'll always write 5-year-old child with mum and dad. Who gave the history from child and parents. If something sounds suspicious, I always write verbatim quotes. He rolled off the bed. He was in the middle of the bed. Make sure that those are verbatim. I always document the numbers and all the systems we talked about. It's not good enough that the numbers are simply at the nursing triage. Those triage numbers may be from 3-4 hours ago. It's important to document the numbers from when you saw the child. There's a safeguarding checklist in the emergency department documentation. You need to acknowledge and sign that every single time. And always document if there's social care input. Here's the safeguarding checklist, and it's both on the computer system and in the paper notes. Have a look at these closely, because any of these, if you circled yes, you need to make sure that you've discussed with a senior. Please remember that all of the high-profile children that have been sadly abused and killed have come through emergency departments, general practices, outpatient clinics. We as healthcare professionals let these children down and have continued to let children down. So for me, every single child you see, you need to consider, could this be NAI? That doesn't mean always physical abuse or sexual abuse. Remember, there can be neglect, there can be emotional abuse. So we need to be considering this in every child that comes in. It doesn't matter if it's my child, it doesn't matter if it's a traveler's child. My final tips about discharging children: do discuss with your seniors, as we talked about. In the department, we have no problem discussing every single case with you. Discuss the rationale with the parents, provide timelines for the follow-up, as we talked about, and say where's most appropriate to go. We have leaflets that we can print off and give them. And more importantly, these days, I often point them to things like the NHS Choices website. Pull up the page for them while they've got it on their phone. You can send it to the other relatives that aren't there immediately just by forwarding the link. And remember, document clearly. So that's my introduction to the PRUH Paediatric ED and how we want you to approach children. These are two of my children. They're now 7 and 5, so they're a lot bigger than this. But I love this moment where my older boy, Ruben, pointed at my younger boy, Rafa's nipple and said, "What is this?" It seemed so obvious to me, but it just wasn't obvious to him. What it showed me was that nothing's obvious in life. So if something doesn't feel right, just ask. So I look forward to seeing you in the emergency department. I hope you enjoy your time in Paediatric ED. Don't forget, always ask.